We all know that reverse shoulder arthroplasty, we have heard a lot about it, become a reliable, successful operation for treating rotator cuff arthropathy. However, concomitant glenoid bone loss creates special challenges that the surgeons need to be prepared to overcome. It's really, glenoid bone loss is a true challenge, and historically, glenoid bone loss considered as a relative contraindication for reverse shoulder. Nowadays, the interest is shifted towards reconstruction of the glenoid bone loss exactly when you reconstruct the acetabulum for the hip arthroplasty. Then my topic will cover the approach to deal with the glenoid bone loss and how to deal with it. First, you start with the X-ray, still the standard method. Then going to the very important tool of radiology, the CT. And from the CT, you have to have an idea about the glenoid version and the head subluxation. You have to put in your mind the different wear described by Frankel: superior wear, which is common with cuff arthropathy; inferior wear with notching; posterior wear with primary osteoarthritis; anterior wear with chronic instability; or the central wear in cases of revisions. Always think 3D. Assess global bone loss: horizontal, anterior and posterior; vertical, superior and inferior; and central. Here are the different types of glenoid bone loss. Starting with the horizontal bone loss, there is a nice classification by modified Welch classification, ABC. A is a concentric or concentric with centrally eroded. B, either posteriorly subluxed or posteriorly eroded and subluxed, or monoconcave with B3 with retroversion. C is retroverted. D is anteversion or anterior humeral subluxation. Then going to the vertical glenoid bone loss with 4 degrees with the favored, with either the concentric glenoid wear, superior and inferior glenoid erosion, or glenoid erosion with inferior pool deficiency. Then finally, the central glenoid bone loss, which can be mild, moderate, severe, or associated with peripheral erosion or not. So you have to consider with the vertical, horizontal, and the central. Why it is important to consider the glenoid bone loss? Because when there is a bone loss, when you do off-axis reaming, will have a poor implant fixation and risk of glenoid fracture and medialized glenosphere with poor muscle tension. Then coming how to solve the problem of the glenoid bone loss. Starting with the reaming, or the so-called eccentric reaming technique, going to the bone grafting, and finally implant fixation with special implants. Putting in your mind that you have to correct the retroversion or the horizontal bone loss, the correct inclination or the vertical bone loss, and the offset with the medialization. First thing is the eccentric reaming technique, which reaming of the one side of the glenoid down to the versions that's similar to the native glenoid. This technique results in medialization of the joint line and removal of significant amount of glenoid bone. So don't use it if you had a greater defect. The goal is to create a flat surface with adequate surface contact with the base plate. And always the surgeon should slightly inferior tilt the base plate, which has been shown to minimize the implant shear, maximize the base plate compression, and facilitate osteointegration. Then coming to the step 2, bone grafting strategies. If you have a central defect, we're using impaction grafting, peripheral defect, wedge grafting, more central erosions, bioreverse, or it's erosions with the posterior or anterior defects with the angled bioreverse. Impaction grafting described by Gerber technique, or whatever that used, this is Steinman also and Koveld, they found that using the autologous head or allofemoral head or ilia graft, you can use either of these to reconstruct the glenoid back to the near normal position. The bioreverse described by Pascal Baulot, that using autologous humeral bone grafting that allow lateralization that reduces the scapular notching with using of long post-base plate that allows for native bone purchase. It can also be fashioned if you have defects anterior or posterior into angled bioreverse. Then coming finally to the third part to reconstruct the glenoid is the glenoid augments. And you have three types, either superior augment or posterior or combined superior and posterior augments. The indications, if the adequate backside contact cannot be achieved with eccentric reaming, such that the potential fixation would be compromised, and in some excessive superior wear with cuff arthropathy. So here are the basic 10 tips to stay out of trouble when you have a case with glenoid bone loss. First, analyze your CT images well. Think 3D. Always put in your mind the horizontal, vertical, and central wear of the glenoid. Second, please ream little. Preserve the subchondral bone stock as much as you can. Third, if the joint line is medialized, please lateralize it to improve the deltoid offset, either with the bioreverse or with the metal lateralization. Fourth, preserve the humeral head you cut it and use it as ideal autograft. Tailor as you need, as you will see in the following cases. 5. Please avoid superior inclination of your glenosphere. The glenosphere must look down. Up to 15 degrees of inferior inclination is accepted. 6. Eccentric reaming option lead to medialized joint line, so bioreverse may be needed. And off-axis reaming will lead to malversion and a metal augment or angled bioreverse will be needed. 7. Minimum 60% of backside contact on good quality bone is needed. Be prepared with your full graft options based on your preoperative planning. Yes, we don't have apps here. Our app is our minds. Full glenoid exposure is mandatory to be able to visualize and palpate the glenoid neck to assess the zero axis with your finger, as we call it, pistol technique. Finally, if everything failed, ream and run, as Dr. Rokot said, hemiarthroplasty may be the final option. I'll present some cases, some of our Egyptian experience regarding cases with glenoid bone deficiency. This is a case of 70-year-old male with neglected anterior shoulder dislocation, 4 months of chronicity. You can see here the deficiency of the anterior glenoid and the dislocation of the head. And this is the CT of the patient. And this is the intraoperative finding. We have here a large glenoid defect, glenoid vault, and rim reduced to half of its size with unconstrained defect. We fashioned a humeral autologous wedge graft, fixed it first with the K-wires, and we made the central drill hole planned in the maximum coverage area. We insert the base plate successfully and followed by the glenosphere. And here you can see adequate reduction of the implant and closure of the subscap over the implant. And this is the post-operative with reconstruction of the glenoid with autologous graft. Another case, 47, it's younger, but with rotator cuff arthropathy, severe degenerative changes, proximal migration, very poor bone stock. As you will see here, you can see here this medialization of the glenoid and maximum erosion of the bone with multiple cysts, deep central glenoid defect. And also the humeral head, proximal humeral head was deficient with big central glenoid defect. And you start humeral preparation, then going to the glenoid preparation, and we decide to use a bioreverse using a graft and inserting the graft over the defect of the glenoid and then the base plate, followed by the glenosphere, and here is the after reduction of the whole construct. And this is the post-op X-ray. Another case, 53, with old fracture dislocation with rheumatoid arthritic patient. And you can see here fracture dislocation. The head is dislocated anteriorly on the glenoid with deficient anterior glenoid. I used the broken humeral head impacted anteriorly on the glenoid. Prepare then the glenoid. Use also a bioreverse with long peg and inserting the plate, base plate. And after inserting the metaglene with maximal lateralization, it was difficult to work inside the joint, so I worked through the tuberosities, inserting the stem, the glenosphere, and then closure of the tuberosities at the end. And suturing the greater and lesser tuberosities together. And here, after complete closure with reconstruction of both lesser and greater tuberosities. And here is the post-operative X-ray. Another case with old non-united surgical neck humerus with pseudoarthrosis. And you can see here that the head nearly fused with the glenoid and the non-united fracture. And this is the remnant, removing the remnant of the humeral head and exposing of the glenoid. The glenoid also suffers from the superior defect. We did eccentric inferior reaming to the superior defect, and we also here used an allograft, femoral head allograft, to reconstruct the glenoid, and inserting the base plate, then the humeral component, and finally close the construct. And I always repair the subscap to close the defect anteriorly, the subscap or the lesser tuberosity together with the subscap. And this is the post-op X-ray. This is a massive cuff tear, looks innocent, but when we go to the CT, you can see how the erosion of the glenoid with the large glenoid bone defect. And you can see this is intraoperative. We take a part of the head and match it to the glenoid, making also bioreverse, and inserting the bioreverse, attach it to the base plate, and insert it. You can see here adequate reconstruction and adequate lateralization of the component and of the implant. Another case with the severe osteoarthritis, you can see here how the glenoid is eroded. Very large erosion, central erosion. You can see also here there is a defect anterior and central. We use an angled bioreverse to reconstruct the glenoid. And here is the post-op X-ray, adequate restoration of the center of rotation and lateralization compared to preoperative marked erosion of the glenoid. The last case, neglected dislocation for 5 years, and the patient is very osteoporotic. You can see here is the CT of the patient with marked osteoporosis and neglected dislocation anterior. And this is the subtraction views. You can see here the defect. And this is intraoperative massive anterior defect. Used an angled bioreverse. And here is the post-op X-ray with adequate lateralization. So to simplify the problem of glenoid bone loss, if you have a central minimal erosion, you can just do eccentric reaming and apply your prosthesis. If there is marked central head defect, you can do an impaction bone grafting. If you have central erosion with subluxation, You have to put a graft, angled bioreverse, and put your implant. If you have marked retroversion, you can tail it with the angled bioreverse. So in conclusion, management of glenoid bone loss is like a Lego. You can rebuild and create everything you want, fashion the head to your defect. Thank you very much.